And only from your Alcan siding dealer.
If you haven't been through it, you'll say, oh, well, you know, so you can't have children. But if you want children desperately, it becomes an obsession.
If you want a child badly enough, and if you just let the world know that you're interested in the baby, one will come.
Good evening, I'm Gregory Jackson. Tonight we talk about infertility, which is a little unusual in itself because so few people talk about it, although so many are affected. In fact, as I think of it here at the moment, this is probably the first prime-time hour-and-a-half television show that there has ever been devoted just to the subject of infertility. For all we know, it may be the last, but at any rate, an estimated 1 out of every 7 couples, more than 10 million people, can't have babies or have trouble at it. Of course, many of those don't know who to talk to or when or where to go for help. A couple can always talk to each other because fertility is always a couple problem, but it's also all mixed up in our minds with sex and feelings of adequacy and usually enormous tension. Often the problem doesn't even get discussed until it's at the explosion stage. Often all kinds of macho dreams and motherhood instincts, not to mention the in-laws, get in the way of the facts. And the facts are, great strides are being made in some areas. In fact, some infertility problems today have nearly 100% chance of being solved. Of course, other problems still baffle the doctors, and that's really what our program is about tonight. What they know, what they don't know, and perhaps most important, what you should know about infertility. And now with some details of what's to come in the hour, my co-host, Joan Lapp.
Thank you, Greg. You mentioned the numbers of people somehow touched or tortured by infertility, and who knows how many more haven't sought help. Maybe one of the biggest hurdles is that no one ever really expects or is prepared for infertility. Most young people starting out worry about getting pregnant, not the other way around. So tonight we're not talking just to those couples who may be working through a problem right now, but also for any couple thinking of having children, or any of you who know a couple in trouble but unsure where to turn. If we raise questions in your minds as we go, as always on Help Yourself, you can call us here in the studio. At the phones are members of the United Infertility Organization, and they're joined by some staff members from the New York State Adoption Service. They'll answer your questions confidentially. Through the course of the evening, you'll see taped reports from couples who have dealt with infertility. You'll meet the experts, and at the end of the program, we'll tell you about some of the literature we found useful in preparing the show, and where you can get more information as well. But first things first. We found 2 things absolutely necessary if a couple is going to get through the process of exposing their intimate relations to timetables, microscopes, and metal probes. The first, emotional support for both doctor and friends. The second, hard facts about human reproduction. Here's what one couple learned.
Total dedication. I mean, you have to be willing to do everything and anything, how silly, how ridiculous, how strange it might seem. If you really wanted children, you had to totally dedicate yourself to this problem until, of course, if they told you it was impossible.
Rarely do psychological factors cause lasting infertility. It's usually a question of biology. During puberty, our reproductive systems undergo changes like the rest of our body. The pituitary gland located in the brain begins releasing a hormone, signaling the reproductive organs to produce their own hormones, estrogen and progesterone from the ovaries, testosterone from the testicles. If those hormonal signals are mixed, the reproductive process can be disrupted. In the female, the vagina is the canal that leads to the actual organs of reproduction, the uterus, fallopian tubes, and ovaries. Under the influence of the pituitary hormone, thousands of eggs, or ova, have been developing in the ovaries. A malfunction in the pituitary, a tumor perhaps, could prevent these eggs from developing, one cause of infertility. Upon ovulation, an egg is released into the fallopian tube, lined with millions of hair-like structures called cilia, and transported toward the uterus by peristaltic movements within the tubes. It is in the fallopian tubes that fertilization takes place. Again, if the tubes are blocked or clogged, a condition called endometriosis, the result can be infertility. In anticipation of the fertilized egg, the uterine walls have thickened and blood supply increased, all part of the monthly menstrual cycle. Obviously, missing a cycle or defective lining can block the process. Within a week, the fertilized egg has reached the uterus, embedded itself into the soft lining, the most difficult part of the journey completed. But if something goes wrong with the genetic makeup of the egg, or the uterine lining damaged, the result is rejection, and spontaneous abortion occurs. In the male, the pituitary hormone is also active. From each testicle, a duct, the vas deferens, leads into the body. There it joins the urethra, leading from the bladder through the penis. Production of male sex cells, or sperm, millions and millions of them, take place in the testicles. Under a microscope, it can be seen how each sperm propels itself by lashing its tail. It is the process by which sperm are made that remains largely unclear. Mistakes in this process can lead to limited numbers or lack of motility or movement, greatly reducing the efficiency of the sperm to reach the egg, if it makes it at all. Each testicle is packed with tubes, more than 5,000 feet in all, where the sperm mature. Traveling through the vas deferens, the sperm mix with secretions from the seminal vesicles and prostate gland to form semen. As in the female fallopian tubes, damage or blockage of this vas deferens tube can render a man infertile. Finally, muscular contractions force the semen through the urethra and out the penis. During intercourse, sperm are deposited in the vagina and propel themselves through the uterus into the fallopian tubes. An egg must be released while the sperm are in the tubes for fertilization to take place. For some, it's the easiest process in the world. For others, with all the potential for biological error, it can be difficult, but not impossible.
Before I couldn't talk about it, it was a very emotional thing. I think a Dr. Jekyll and Mr. Hyde, I would really blow up, or I was on edge all the time because it was an obsession. After Mahler, I started talking about it to various people. And I found out that there were a lot of women around who couldn't talk about it. They're always hoping that next month they'd be, that would be the month. I found that we were very naive. I think it would help a lot of women to know that there are a lot of testing that can be done. Many. I mean, if they are just having the Rubens test and somebody just tells you to take your temperature, this is not enough. They must know where to go.
What did you all know when you started this?
Nothing. Absolutely nothing. We never believed it could happen to us. We bought this house before we had children. I mean, we anticipated filling it up right away. The shock was one thing that really was amazing, that we had a problem. We did not know anyone that had a problem.
I mean, everybody has kids, right?
Yeah.
That's right, it's
and
natural.
Everyone around us was having, all our friends that were at the age, they were pregnant and or had at least one child.
Did either of you ever run into the doctor whose best prescription was just relax? Told you, relax and go home?
You know, that was the first
That was the
doctor.
first doctor, yes.
For Toby and Lenny Suroff, the problem was not physical, it was chemical. After a year of testing with the right specialist, it was determined that her internal chemistry was hostile to his sperm, killing them before they could get to the tubes. There began an antibody program, and to compress a long story, today they have 3 healthy children. But it wasn't easy.
They started me on a drug treatment. Of course, I'm allergic to penicillin, which is the most common drug, so they had to be careful. But he told me I still had about 10 things I could take. And
So you started taking antibiotics?
I started, yes, antibiotics. And I'd say it took about 14 or 15 months. I mean, the total time I went there, and I became pregnant. I took, I think, 4 or 5 different kinds of antibiotics.
And that's Marla.
There she is. And I'll tell you, what a thrill. I get very emotional when I think of that day.
So that was child number 1. You had 2 more.
Yes, and I had problems.
Had you found the answer by then, or did you have the other 2 easily?
No. Then we started trying right away. I figured if it's going to take me 4 years, I better start right away. So we had to try all different other things, and I went through the whole battery of tests. It took me another well, they're 4.5 years apart. So it took me over 3.5 years of going back and forth, an hour and a half each way to the city. Well, about 3.5 years later, I conceived Mark. And right after Mark, I said, well, I'd really like another one. Could we really try it? You know, would I be lucky enough? And we said, I'll give myself a year or so, but I won't go through what I've gone through.
That was 3 years ago. And indeed, it took another full year of trial and error. But today, here in their home on Long Island, is the reward. They call him Matthew. Because infertility is a couple's problem, the diagnosis and treatment is a team affair, with a medical doctor just one member of that team. Dr. Wiley Hembry is an internist and associate professor of clinical medicine and OB/GYN at Columbia's College of Physicians and Surgeons. He's currently in charge of the research program in male reproductive endocrinology. Roselle Schuben-Stein is an infertility counselor therapist who works with a gynecologist in treating and counseling the infertile couple. Dr. Hembry, Mrs. Stein, I was personally very taken with Mrs. Suroff's comment about the middle of the tape in which she said, I just couldn't talk about it. It was so emotional, which I think points very well to what a really emotional personal crisis this is for a family, for a couple, an individual. I wonder if each of you would comment, Mrs. Stein, perhaps you first, on just what is this emotional impact that happens to people?
Well, for one thing, it's not a problem that couples anticipate having. I think most of us start off our sex lives actually worrying about how not to get pregnant, so that when this becomes a problem, it's rather a shock. And it requires a period of adjustment just to acknowledge the fact that, quote, we are having trouble having a baby. For another, because sexual activity is so intricately tied into trying to conceive, a couple's sex life is going to have disruptions, either from a mild to moderate to severe extent. And because their goal then becomes trying to conceive, the goal of pleasure in sex becomes secondary. And so a whole variety of sexual problems begin to arise.
Kind of sex on schedule isn't fun for anybody.
Sex on schedule, sex on demand, the whole knowledge that someone is passing judgment on your sexual adequacy in the minds of some patients. The testing itself is a problem. There's the fear of pain, the problem if a patient has to be hospitalized for some of the diagnostic tests. It's upsetting to have one's sex organs and one's sex activities being closely scrutinized. These are some of the problems.
I would assume that there is a sense for women, but I deserve motherhood. I mean, I'm a woman. I must be able to be a mother. That ought to come into it, I would think. And I wanted to address a question to Dr. Hembry about the other side of it. For men, this is a very macho culture we live in. What happens to men when they find they are infertile?
I think the impact of finding that they have a problem is as severe or perhaps more severe, even though attitudes have changed a great deal in the last 10 to 20 years toward men's sexuality. I think most men still feel that if they have normal sexual function, that indeed they can father children, they can be a father. For men, paternity and sexual function are linked very closely, perhaps more so in our society than they are for women. So the notion of maybe not being able to father a child is a great assault to their the whole picture of their own sexuality.
Would either or both of you say that that's the most significant difference between the male and female reaction, or are there other very different feelings, for example, Mrs. Stein, that a woman might have that isn't seen with men who face the problem?
I think there are different aspects of the problem for the male and for the female. Men in general, and this is a generalization, true, but men in general are not used to talking about what is troubling them. So a lot of their anxiety and a lot of their frustration with what's going on is kept pent up. A man is also not used to going to a physician on a regular basis to be examined, as a woman is used to going to a gynecologist. So for a man to have to go to a physician and be examined and have his have himself questioned the way he is when he goes to an endocrinologist or a urologist for an infertility problem. He is putting himself in a position which he has not been accustomed to before.
That really raises the interesting question, too, of what kind of help one seeks. Now, I don't know that there's any real analogy to a woman's regular relationship with a gynecologist. So is it simply assumed that that will be the first doctor who deals with this problem?
Well, I think because it's generally talked about and articles are written about going to gynecologists for infertility, most infertility experts are gynecologists, it's natural to go to a gynecologist. Men don't go to gynecologists. I think what this evokes in the couple is, first of all, a sense of potential loss to them. They came together so that they could have children. They tried to have children and could not. They faced that loss. Then they don't know where to go. So there's a feeling of being lost in the medical community for that. And then what the medical community often offers to them is a separation. One goes to the urologist or the internist, the other goes to the gynecologist. Often the two don't talk to each other, and there's a further sense of separation. This, I think, takes a great heavy toll on the individuals who are trying to go together to solve their problem and have no one in the medical community that they can go to together.
Is that changing at all? Is there any sense of organizing this kind of treatment with several people dealing with the couple?
I think more and more that's the case, certainly in throughout the country. The Fertility Society, Andrology Society, endocrine societies, all professional groups, I think, are urging more of us to collaborate, talk together, and coordinate our efforts.
We try to maintain a liaison in our office, which is a gynecologist's office, with every urologist or endocrinologist the husband is seeing.
Are there specific experts to whom one is eventually sent if you have gone through several doctors and you're really not getting any results? Are there the people who are at the very top of the profession, the fertility experts? Do they exist?
There are people who are specifically committed to the study and treatment of infertility problems, and there is the American Fertility Society, which is the academic and clinical society which publishes a journal and recommends patients to people in different parts of the country.
When should a couple go? Let's assume that 2 months, 6 months, 8 months, a year has passed. When do you feel that you really do have a problem?
I think it depends upon how they first sense the problem. If the woman has a problem with irregular periods, abnormal bleeding, no periods at all, she may sense that she has a problem and should seek the help of a gynecologist in defining that problem. If everything appears to them to be normal, and they've tried without using contraception for at least a year, and are sure that indeed they've had adequate sexual exposure during that period of time, then that's the time to seek some help.
You say a year. I'm wondering whether that would be different if, let's say, a couple were over 30.
Yes.
Does age make a difference?
Yes, I would think if they were over 30 and have never had a pregnancy, then in that case they ought to seek the help of someone sooner. I think I would agree also with what you said about what their index of suspicion is. The whole business of irregular periods or painful periods, of a history of abdominal surgery where the possibility of pelvic adhesions may enter the picture, should all raise one's suspicion and perhaps point you to the direction of a specialist sooner.
Yes,
so we do have a sense then what to look for, who to look for, and where to go.
Yes.
Dr. Hembring, Mrs. Stein, thank you very much.
You're welcome.
Well, the hardest thing a couple has to do is to go through an infertility workup. Knowing what to expect certainly helps. Greg?
One place to turn for help this evening is right here. We remind you again that we have experts at the phones here in our studio, and through the course of the evening we'll be putting that phone number up to handle your questions with all confidentiality, so feel free to call us. Our next guest is Dr. Charles Dubrovner, who is a gynecologist and works, incidentally, with Ms. Stein in treating the infertile couple. He's a clinical associate professor of obstetrics and gynecology at the New York University School of Medicine, and he has a special interest in infertility. Doctor, welcome.
Thank you.
The first thing that we're always told about when incidentally, it seems like it's always the woman who deals with the problem first, I think because she goes to a gynecologist routinely and a man doesn't. And the first thing we always hear about is that temperature chart. We have a slide of a typical sort of chart. If we could have the slide put up here. Perhaps you could look at this and just tell us generally what we're looking at.
The temperature chart takes advantage of the fact that progesterone is produced when the patient ovulates, and that has the ability to make the body temperature rise. So by charting the temperature every morning as soon as the patient awakens, she can see the point at which her temperature reflects the production of progesterone and goes up. Ovulation is best correlated with the point right before the progesterone is produced, or at this low point.
So the woman starts taking her temperature at, say, the start of her menstrual cycle, and it goes along here, and then all of a sudden it takes a dip.
Sometimes it dips and sometimes it doesn't. The dip is not always there, and therefore you can't use the temperature graph to say, aha, today is the right day. You can sometimes look back and say, yesterday was the right day. So this is a retrospective tool and not a prospective tool.
But once an egg has been produced, then the temperature does go up in this way. Now, any woman at home obviously could start doing one of these charts every morning at, say, at 7 before you get up. And what does the chart tell you specifically? I mean, it seems like every woman has to go through this, and it's rather cold.
Well, if there's a single point at which the woman begins to focus on the problem of her infertility, it's this temperature graph that she feels she is chained to. So we don't feel that this is something that should be continued for a long period of time. It helps me in several ways. First of all, when I see a nice biphasic temperature graph, a low phase and a high phase, and the high phase is maintained for 14 days, I'm generally at least reasonably sure that the patient is ovulating. There are also certain tests that are timed relating to ovulation, and the temperature graph lets me know whether these tests have been done at the proper time.
Now, there's also the man. So when you see them, the first thing you want to see a semen analysis of the man. You start the woman on a temperature chart. This is all. This is something, and then you also want that next test, the postcoital. Tell me about that.
Well, we
have incidentally another slide of the female anatomy, and perhaps that would help in your explanation if we could see that.
The cervix produces a mucus that is receptive to sperm only at a short period in the menstrual cycle, right at the time of ovulation. The couple is instructed to have intercourse as
Say the night before?
At the night before or the morning of. It really isn't as important as people make it out to be, and we shouldn't try to make this something that has to be too much of a ritual. And the couple has intercourse. The woman comes into the office the following day or the same day, and cervical mucus is aspirated from the canal of the cervix right here.
You use something just like this.
A syringe. There are various types of instruments, and we get a column of mucus. We then put it on a slide.
You take it right here at the...
Right from the cervical opening, right here.
Okay, so here's the vagina.
That's correct.
And you go right to there.
That's correct, and we actually, by pulling, we can pull down cervical mucus from a fairly long distance in the cervical canal.
Okay, and what are you looking for?
Well, we want to see the quality of the cervical mucus. Is it the kind of mucus that we know is a receptive type of mucus? We want to know how many sperm are in the cervical mucus, and are they happy? Are they motile? Are they swimming around? And are they there in adequate numbers? This lets us know several things. First of all, that there are enough sperm. 2, that the environment is suitable. And 3, all the couples seem to have this nagging question as to, are we doing something technically wrong?
Sexually.
Sexually.
And you're proving that.
Am I staying in bed for not long enough? Are we doing something wrong position-wise? If I can show them a good postcoital test, I can reassure them. Don't worry about your sexual positions. Don't worry about intercourse. Relax. Let at least that part of thing happen naturally.
Okay. So far, everything's good, but they're still not having children. Then the next thing is a biopsy? Is that
an endometrial biopsy is often performed? This gives us indirect information as to the
tell me what
ovulation.
A biopsy is.
We take an instrument and we go through the cervix again, and we suck or scrape a tiny little piece of tissue from the lining of the uterus. And this is done either right at the time of a menstrual period or perhaps a few days before. And since the endometrium is under the influence of the hormones of ovulation, if we find a well-developed endometrium showing good hormonal effect, we know that it will provide a good implantation site.
In effect, you're checking the lining of the uterus.
The lining of the uterus and indirectly the ovulation hormones. Which
okay, that turned out all right. That's the next thing. Well, you take x-rays?
We would often take x-rays, which show us 2 major things. First of all, the contour of the uterine cavity. The shape of the uterus. Is there any abnormality that would interfere with this uterus expanding to support a growing pregnancy?
We have a slide of an actual x-ray, but first here I would like to see if we could have a normal slide here. Okay. There it is. That's an actual uterus.
More or less triangular, fairly regular shape is the normal uterine cavity. And if we see that, we know that at least the shape of the uterus and the contour is normal. Here we see the fallopian tubes arising from the 2 angles of the triangle. And in this case, we see the tubes are filling with the radio-opaque dye and beginning to spill from the ends of each tube.
Okay, so in other words, you're checking to see that the tube is clear all the way from the ovary, and this looks fine.
That's right.
I think on our next slide, we have show where there's a blockage. Could you explain
this patient, you can see again, the uterine contour is normal, but the tube only fills a very short way beyond the point where it leaves the uterus. And we have a block. This might have been a patient who's had a tubal ligation, as a matter of fact, but we can see here that the tube is blocked totally beyond this point on both sides.
Obviously, the woman can't get pregnant because the egg can't come down the tube.
That's exactly right.
All right. Now, so you've done a workup and you do the x-rays, but in this case, let us say that they seem to indicate that, again, the tubes are clear. I often hear of the Rubens test.
Mm-hmm. Rubin test or tubal insufflation. The patient will often say, I've had my tubes blown. We are using the test less and less. I think we find that it's a painful test, and it really doesn't give us any information that we will not get in greater detail and in greater sophistication from the x-rays. So we'll go to the x-rays primarily and do the Rubin test less.
Let us now assume that you've done all of these and you still haven't found out. You can actually now insert an instrument and take a look, a laparoscopy.
Correct. We're still looking at just shadows on these x-rays, but when we really want to find out what's going on, we can actually now look directly into the abdominal cavity. Here's a diagram of a laparoscope being placed through the patient's navel, and it has a lens and a light.
Let me make sure I'm accurate. Here's her belly button.
That's right.
And you come through the belly button and you're actually looking in there with a light.
Directly at the uterus.
And this is another
ovaries.
instrument holding back the fallopian tube there?
We can move the tube around. We can manipulate certain structures. We can take a biopsy from the ovary if we wanted to.
This is the ovary here?
This is the ovary right here.
And your eye, you're looking right through here?
Right through there. That's correct.
Okay, we do have some slides of showing an actual laparoscopy and what you see. First, if we could take a look at a normal.
Well, here's the body of the uterus. Here are the tubes coming off the uterus. And someplace in here, we would look to find the ovaries sitting close to the point where the tube is and the uterus is.
Now, you're looking for if there's an adhesion, perhaps. We have a slide showing an adhesion where yes. If you could explain what we see.
This patient has a condition which we call endometriosis, where there has been an abnormal location of the lining of the uterus so that the patient menstruates internally each month at the same time she menstruates externally in the normal way. This produces an inflammatory reaction which can produce scar tissue or adhesions. And we see these little fine bands of scar tissue that have formed, which serve essentially to keep the tube from moving as freely as it should and keep it from having access to the ovary.
We often hear about a venereal disease. We also have a slide showing what happened to one of these tubes with that disease in itself. Now here is a patient that, can you explain what we're seeing?
This patient most probably had gonorrhea, which affected the tubes, originally filled them with pus, and then close them at their ends, so that this end of the tube, which normally should be what we call the fimbriated end, which has a delicate finger-like projections that are necessary to pick up the egg, is totally destroyed, and we're left with just a large, clubbed, blunt structure with no real function.
So actually, you've seen this by this little instrument, which allows you to look in. The test that we've talked about so far, just very briefly now, how long a time are we talking about before a couple should get some idea what's wrong?
Well, it doesn't have to be too long. Each of these tests is best done at a particular point in the menstrual cycle. So giving some scheduling problems and things, I would say that the entire study that we've talked about so far should easily be done in 2 months.
And talking to you earlier, you estimated this is the cost, some of it picked up insurance, about $1,000. Would that be accurate?
It's a little high, but I would probably think that including the hospital admission for laparoscopy, that's probably about what it involves.
Okay, well, the next step then would be treatments. But before we discuss specific treatments for some of the causes of infertility, our colleague Carolyn Weidman is over at the phones with some information about a very special service regarding infertility. Carolyn.
In many parts of the world today, the emphasis is upon zero population growth and birth control. But that's a very new thing. For centuries, mankind has been worshiping fertility symbols and envied the family with many children. Not surprisingly then, the infertile couple has been victim to folklore and superstition, gimmicks and gadgets, all promising a cure and all mostly harmless. The danger is that they can delay a couple's investigation into real medical problems. So where can you turn? One place to start is the United Infertility Hotline, open 24 hours a day, 7 days a week. Eileen Mitchell is president of the United Infertility Organization. Eileen, who answers the phones when people call?
When people call, they're actually getting an answering service. If they will leave their name and number, they will be called back within a period of 2 weeks. They'll be called back by a member of the organization who has had an infertility problem and who has gone through everything that anyone would go through. Everyone is very well versed in all matters of infertility.
If they have any specific medical problem, do you have any medical advisors that can call them back about that?
Yes, we have physicians who will call them back if the question cannot be answered by a member of the organization.
When we were doing research for this program, we were wondering, when we first looked at your organization, into the kind of information that you can give people. What can you really tell them and how can you help them?
Well, one of the things that people frequently do not know about is what an infertility workup consists of. So usually we try to find out what they've had, and then we try to fill them in on what needs to be done. We also have a physician referral service, which can be helpful. Also, we provide support. Everyone who operates the hotline has been through the infertility problem, and therefore can lend a lending ear to someone who needs comfort.
So they know it firsthand.
Absolutely.
For the most part. Okay. When people call, and I'm sure you've had, how many calls do you get a year?
We get over 1,000 calls a year.
And what kind of information or misinformation is asked? What do people not know? What do they seem to want to know?
The most common thing that people do not know is what an infertility workup consists of. Very frequently, we have someone on the phone who said, I've had everything done and I can't become pregnant. The reality is that they have not had everything done, and that there are many options open to them, and all they need to do is to investigate them.
Okay, now where can people call?
Okay, the hotline number is 914 area code 723-1687. It is available 7 days a week, and it's a 24-hour-a-day service.
Okay, thank you, Eileen.
Thank you.
What do the experts say? No magic potion, pill, or device can increase fertility, nor prevent infertility. Their advice is to seek professional help from a medical team that specializes in treating infertility problems. And don't hesitate to educate yourself. I'll be back later with some reading suggestions and a preview of our Help Yourself kit. Greg?
Who would like this one?
Good evening. We're back with you. Let us remind you that the phones are here. You've just heard, so feel free to call us through the evening. And through the evening, we're going to try to answer the kinds of questions that are coming over the phones. We ask them to jot them down and note them. I have a first question here that one that comes up quite often. Dr. Hembry, perhaps you can help us with a question. What relationship does overweight have to do to infertility?
There are two things that it might indicate. In some very rare cases, a change in weight, either an extreme gain or an extreme loss in weight, may indicate the onset of an endocrine problem that has to be carefully worked up. However, the notion that overweight means that your thyroid is underactive and that being treated with thyroid will help either in the man or the woman is nonsense. And thyroid really has little role in helping with fertility problems.
Well, I think what they're saying, kind of fat man or a fat lady, do they have more trouble or less getting pregnant?
Fat women who have trouble with ovulation have more trouble. If they don't have trouble with ovulation, they shouldn't have more trouble.
And men?
And men, there's no relationship between overweight and infertility.
Joan?
And there's also some indication that underweight women also have ovulatory problems.
Right.
Extremes in both directions.
Right.
Ms. Stein, I have a question for you. What on earth is an infertility counselor?
At the moment, there aren't too many of us. I would define an infertility counselor as one who has a background in the dynamics of human behavior and also a background in the problems of human reproduction and can coordinate the two.
A question that just came in over the phone. What can be done for a woman who does not menstruate after stopping birth control pills? Is she infertile? Dr. Brodner, we hear that question frequently about pills.
We talk about post-pill
Yes.
amenorrhea. This is often a very short-term problem, and within a month or two, she's back in a normal cycle. There are some women who have gone as long as 6 months to a year without ovulating after the pituitary gland has been put to sleep by the birth control pill. This usually resumes itself, but sometimes certain kinds of drugs are necessary to stimulate the pituitary to start working again.
Here's a question about vitamin E. Does it have any effect on fertility? Dr. Hembry?
No.
No. Quick answer.
A woman called in, I've had several abortions and now I find I can't conceive. Is there any relationship, Dr. Brodner?
Well, there often is. She might have had an infection that was mild enough not to let her know that she had it, but enough to cause some problems with her tubes and ovaries. The lining of the uterus may have been damaged in some way, and this could also affect the implantation site for the ovary, the fertilized egg.
So your answer is that an abortion...
Yes. It can produce problems if complications have occurred, and she may not realize that they have occurred.
Might I interject that if these are spontaneous abortions that have occurred, she didn't indicate which they were, if they're spontaneous abortions that have occurred, they certainly should be evaluated by a genetic counselor, and perhaps both individuals evaluated very carefully for the presence of a genetic or chromosomal abnormality.
Ms. Stein, we've been trying to have a baby for over 2 years now. Now I'm not so sure I want children, and I feel guilty. Is that normal?
I think every couple, when they first begin planning a family, have some ambivalent feelings about what a child is going to do to their style of life. I think one of the unfortunate problems about having an infertility problem is that you become so focused on how to resolve the medical problems that the psychological dynamics of do we really want this child kind of get lost.
A man called in and he'd had a vasectomy. Now he wants it reversed. Dr. Hembry, what are the odds that microsurgery or resectioning of a...
I think that depends on the surgeon that you find. In approximately 20% in most series of revascular or reanastomosis of the vas are successful in achieving pregnancy in most series. However, some doctors have better success, and I would suggest that they shop, if they want to have such an operation, that they shop and find out what the success rate is of the doctor they find.
Well, let me just ask, are the chances good, average?
I would say they're below average.
Okay.
And we can get a quick answer to this one. Is there any evidence that smoking interferes with either egg or sperm production? Anybody know?
We certainly know that smoking interferes with pregnancy, and the fertilized egg, once it's in the uterus, needs a certain blood supply, and the smoking constricts the vessels to the uterus. But we really don't have any good information that smoking itself interferes with fertility insofar as conception is concerned.
Same thing is true of sperm.
I'm sorry.
Same thing is true of sperm. We do not have the information to know whether it has a significant effect.
Let us move along. When most of you watching this program tonight were born, science didn't have much to do with it. The vast majority of parents then either could have children or they couldn't, and that was it. Today, over half the seemingly infertile couples in this country can be helped, and it's not happening so much in the bedroom or in the new sex technique manuals. The strides, truthfully, are elsewhere. It's in laboratories like this one at Columbia Presbyterian, where researchers are working to unravel the reproductive process. Fact is, there's a lot they don't know, especially about males. Live human sperm, in this case, displayed from a slide onto a TV monitor, show a wide range of characteristics. In any specimen, they study the sperm count, its motility or movement, and the morphology or condition of the individual sperm. Why does the sperm behave the way it does? What about its motility? Why is the count high or low? In many cases, they just don't know, but they're looking. In this experiment, for example, they are testing earlier data indicating that regular use of marijuana directly lowers the sperm count. The rats here are given daily doses of carefully controlled, government-grown and rolled marijuana. And they're gearing up right now for further drug studies on paid volunteers whose sperm will be exhaustively analyzed over a long period of time. With women, they know a lot more, and they can do a lot more. They're making huge strides in being able to regulate a menstrual cycle, as well as to spur ovulation, almost, it seems, on demand. Other research ranges from use of antibodies to hormonal control, from new donor insemination techniques to a better understanding of the genetics involved. And possibly on the horizon is the fertilizing of a couple's egg in a test tube and then implanting it in the woman. But all that's years away. Right now, the circumstance is, if a couple has an infertility problem, pray it does not lie with the man.
The problem in an infertile couple is that sperm function is less than adequate. Low sperm count, poor motility, and so on. In most of these individuals, we cannot really put our finger on an endocrine problem that could be the cause of this. Most of these males are endocrinologically normal, and therefore we don't know how to treat them.
But if it's a woman?
It's a woman, as an example, you know, the main problem obviously in terms of abnormalities of ovarian function is lack of ovulation.
No egg.
If no production or no rupture of a follicle every month and delivery of an egg into the tube, if this is the problem, we can treat 98% of them successfully.
What major strides have you seen in the areas of helping infertility in the past 5 or 10 years?
Oh, there are enormous strides. If you say 5 years, this is a little bit short, but if you're willing to say 10 to 15 years
ago,
we specifically, as an example, in patients whose infertility is due to problems of ovulation, at this time, 10, 15 years ago, you probably could treat somewhere between 2 and 5%. I mentioned before, at the present time, we can treat 95 to 98% of this patient. It's a real breakthrough. And it's a very satisfactory one because it makes up close to 1/2 to 1/3, between 1/2 and 1/3 of all problems of infertility.
Can be treated successfully.
If with these new methods to induce ovulation.
What's your feeling about fertility drugs as a form of treatment?
They belong to the category that I mentioned of, on one side, they are enormously successful and their use is extremely satisfying. And on the other hand, they are greatly overused. Fertility drugs, I mean, we're talking now, for instance, substances like Clomid or gonadotropins, should only be used in women where there's a problem of anovulation. In fact, there is a good deal of evidence that if given to women who ovulate, just, you know, in the idea, if you ovulate, a little push will make you ovulate better, which obviously is scientific nonsense. But there's a great deal of evidence that in these women actually it is counterproductive and may well work in a contraceptive fashion. This is true to some degree with Clomid, this is true to some degree with the gonadotropins. But if you use them in the right indication in the woman who doesn't ovulate, it's a success story. 95, 98% of women that you will see with anovulation will respond. And out of this 95 to 98% that respond with ovulation, somewhere around 60% will get pregnant.
Do you feel that fertility drugs are overprescribed?
Oh yes, no question.
Who's overprescribing them?
The physicians.
Your family doctors?
Perhaps more frequently the family doctor than the fertility expert, but even by a number of so-called fertility experts, I think the gonadotropins as well as Clomid is overused.
We're going to be raising some doubts in people's minds who are watching the show tonight who may be on these drugs. What do you recommend?
Well, I would not have any problems of saying that a woman who knows that she ovulates should not be treated with these drugs.
My particular problem is that I have a tumor on my pituitary gland, you know, in the back of my head. So this precludes all reproductive action at all.
Peggy Jo was a perfect candidate for a fertility drug. She did not ovulate. After her husband, Bill, was tested, she took the drug Pergonol, and they did indeed have 2 children. First a daughter, 12-year-old Meg, followed by John 2 years later. And then, about 8 years ago, they decided to try for a 3rd child, and shortly thereafter shook up their New Jersey neighbors in a good part of the country with a triumphant arrival of those who came to be known as the Keenast quintuplets. And today, all that adds up to a lot of fun, the way the parents tell it. We also noticed a lot of bicycles.
Oh, well, certainly it was a big surprise. But, oh, of course it's been fun. I mean, I would recommend it to anybody who has nerves of steel and doesn't really...
The finances of the Aga Khan.
Oh, well, I don't know about that, but yeah, well, that would help, definitely. But, you know, as long as you don't want your house looking like Better Homes and Gardens, just switch through, have a lot of kids, right?
Well, you know, we're pleased, I mean, you know, obviously, but I think the drug that they used when Peggy Jo had the quintuplets was supposed to have some kind of inhibitor in it or something to cut the frequency of this down, which obviously didn't work. But, because we did have the multiple births, but it's not a disaster.
Have you been called on for instant experts?
Only by friends. Oh, yes, as a matter of fact, people have written to me, and I'm such a terrible correspondent. I write one letter every 10 years. That if anybody out there has written to me, I'm sorry, I haven't written back. But people do write, and really, I can't tell them anything that their own gynecologist couldn't tell them, certainly.
I guess I find it remarkable how the two of you handled what could have been certainly a difficult circumstance.
We're relaxed. We do our share of hollering and screaming at the kids and at each other, and but it's just, you know, the people that we know with large families are, you know, all of them. They do the same thing with their children, and you know, it's like someone said, if you don't, they'd rather be hollered at than never talked to. You know,
it's very likely someone watching the show right now this evening has a doctor who's recommended they take fertility drugs. What would your reaction be?
Oh, yes.
Oh,
yes,
sure.
yes.
Right. Would you recommend quintuplets?
Sure.
Well, it depends on how sporting they are.
Yeah.
And Peggy Jo Keenast is certainly sporting. She's also a marvelous success story, a very unusual one. But of course, as we learned, if the infertility problem is with the woman, you have a much better chance of solving the problem. So we're going to talk about treatment. Dr. Dubrovner, let's talk about treating the female infertility problem. And if I have my facts straight, there really are three areas. The ovarian problems, ovulating, tubal, and cervical, correct? Mm-hmm. Now, we learned that if it's an ovarian problem, it's pretty easy to take care of. And fertility drugs is what comes to mind most quickly. We learned in the film that these may be overused. What's your opinion about that?
I think they probably are overused. There are ovulation problems that are secondary to other hormone abnormalities in the thyroid gland and the adrenal gland. And if these are corrected, then the ovary will work automatically. So just giving a fertility drug because it sounds like this is the proper thing to do certainly doesn't help these people. And a woman whose tubes are closed, or has a husband who has no sperm, she can take all the pills that she wants, and she can ovulate with 7 eggs. She's not going to get pregnant.
Do you think there's some patient pressure on doctors to prescribe a medication like that? Maybe this is a kind of pill-popping society.
I think Americans like the hard and fast fact, I'm taking a pill and it's going to do something. I think that's probably true.
We hear the terms Clomid, Pergonal. Those are the two specific drugs. What's the difference, if you can say quickly, between them?
Well, Clomid stimulates the pituitary to work and do its own functioning. Pergonal bypasses the pituitary and supplies the gonadotropins that the pituitary would ordinarily produce directly to the patient and stimulates the ovary directly. Mm-hmm. Therefore, you are more likely to overstimulate the ovary using a drug like Pergonal than a drug like Clomid, where the pituitary can only work so hard, and therefore you cannot overstimulate quite to the same extent.
And of course,
it's a safer drug.
As was pointed out in the film, if those drugs are prescribed when ovulation is taking place, it can be a birth control device.
That's true, and you can produce problems by producing ovarian cysts or certain other things where you overstimulate the ovary.
Mm-hmm. Let's move into some of the tubal problems, which I understand account for about 1/3 of the infertility problems in women. Are always the procedures to be used surgical, or are there any medical procedures in taking care of tubal problems?
Well, there is a procedure which is called hydrotubation, where a fluid is placed through the tube, and the tube is essentially stretched by the fluid pressure. Sometimes this will have some effect on a tube that has been minimally occluded. Usually, however, surgery is what is necessary.
What you just described is a test as well as a treatment, though, isn't it?
That's right. With an educated finger, you can get some idea as to how much pressure you have to put on that fluid to get it through the tube, and that will give you some idea as to the function of the tube.
Then it's possible that some of the tests, actually, with tubal problems, can be part of the treatment.
Sometimes, yes.
With endometriosis, must it be surgery? Or?
Well, endometriosis can produce infertility in two ways. One, by producing adhesions, as we saw before, which can actually mechanically block the tube. And then in a more subtle way that we don't really understand, the presence of endometriosis in the pelvis in some way makes the patient less fertile. When there's endometriosis without adhesions, various drugs can be used to eliminate or at least suppress the endometriosis to a great extent, often resulting in fertility. When there are adhesions, you must mechanically remove the adhesions. The drugs do not do that.
Maybe we could look again at a cross-section of the woman's reproductive system and see here that there is a lot of room where some of the blockage could take place. I'm wondering whether it matters exactly where within the tubes there might be a blockage.
I think the important thing to remember is that the tube is not just a pipe. There's a lot of dynamic function that must go on. This tube must have a lot of physiological activity other than just acting as a conduit.
Here in this very remarkable film, and what we are seeing is actually the process of the egg passing into a fallopian tube. This is a rabbit which is ovulated, and the film, I should point out, was produced at the University of Washington. But it shows very clearly how this passage must be clear and how all of the parts must work properly. Is this the cilia here that we're seeing?
Those are the ciliated cells, and that's very true. A lot of patients can have tubal patency restored, but not all of the patients who have patent tubes can become pregnant because the physiology of the tube has not been restored or has been so badly damaged that it cannot be restored.
Here we should point out that the darkened area is dye that's been injected so one can see the egg. These are peristaltic movements,
That's right.
aren't they?
The tube must squeeze the fertilized egg along. The ciliated cells will produce currents that will move the egg and also help in sperm transport. The tube is nourishing this fertilized egg. It's supplying it with various energy requirements and nutrients that the egg needs for its existence. There's also a timing factor. If that egg remains in the tube for longer than 3 days, it may acquire the capacity to implant, and then the patient may develop a tubal pregnancy.
And then what happens?
Well, an ectopic or tubal pregnancy will eventually burrow into the wall of the uterus to the point where the tube will rupture, and it can be a very catastrophic event.
What about microsurgery in terms of tubal problems?
Well, if we think of microsurgery as a philosophy and not just a technique, I think microsurgery is extremely important. The concept of meticulous hemostasis, of careful placement of sutures, of separating tissues along anatomic planes, and things of this sort, I think it's very important. Some of these things require magnification to see exactly what you're doing. So where the magnification is necessary, well, then that's fine. But the technique of microsurgery works well whether or not the actual microscope is used, if you can see what you're doing.
I think what we tend to hear it referred to is in undoing a retying of the tubes. Is that just hearsay, or is that true?
That seems to be the area where microsurgery has proven itself as most effective, because in putting together the tubes, we're dealing with very, very narrow diameters. Other areas of tubal pathology, it's a little larger, and you can see it with the naked eye, and you can deal with it without magnification, but the magnification sometimes is helpful in choosing the proper location and the proper plane.
Okay. We've talked about ovarian problems, tubal problems. Very quickly, there's one area that we haven't touched on, which are cervical. These are treated medically, is that correct?
These are treated medically, but sometimes technically. In other words, if we cannot improve the environment of the cervix by eliminating an infection, by improving the output of cervical mucus, sometimes we can try to bypass the cervix by doing husband insemination, where we'll take the semen and mechanically try to put it up higher into the cervix or even into the lower part of the uterus where it is not getting by natural means.
There are clearly then many, many methods by which women can be treated for infertility. Well, since 40% of infertility is due to a male problem, however, treating the couple's infertility may mean treating the man. So Greg and his guests will tell us what's involved.
Unfortunately, the treatment for male infertility is not as advanced as it is for female infertility, and that's due to the fact that very little is really known about the male reproduction system. Dr. Hembry and I are now joined by Dr. Nicholas Romas, who is Associate Professor of Clinical Urology at Columbia's College of Physicians and Surgeons. Dr. Romas, perhaps we could start this discussion of male infertility with, if you could just give us a brief review of the anatomy. We have a slide here of the male anatomy, and as they put it up here in a moment, perhaps we could talk about it. And if we don't have the slide, you could talk to us generally about the reproduction system now?
Well, this is the testes here where the sperm go through several processes before they're formed. This entire process takes approximately 70 to 75 days. Then the testes are transported to the epididymis, which is this structure lying posterior to the testes, and the sperm through this process also goes certain maturation. They are transported into the vas deferens, which is the tube that connects into the urethra. Now at this point here is the seminal vesicle or the ampulla, where the sperm are stored and released when ejaculation occurred down the tube, the so-called urethra, out to the tip of the penis.
You mentioned that it takes about 75 days to produce the sperm here in the testes. Is it constantly being produced? I can imagine a man out there thinking it takes 75 days and it's used up.
It is constantly being produced at all times, and there's always a supply present. It takes approximately 20 days for that sperm to be transported and to be stored, and there is definitely a constant production.
Dr. Hembry, perhaps we could talk about, we also have a piece of tape of some actual live sperm on a slide, because what you always hear about is a sperm analysis.
Right.
If there's some doubt, or even if you can see here now, this is some actual human sperm. What would you look for here, and just off the top of your head, so to speak?
The first thing that you look for is the total number of sperm that are in the ejaculate, and it's difficult to give absolute figures as to what is a normal or an abnormal sperm count, but certainly when it's below 50 million total sperm in the ejaculate, that's a suggestively abnormal sperm count. However, more important than number is the movement or the function of the sperm. Now, this sperm that you see here is almost moving normally. Its direction of movement is not as rapid as it should be. Some in the previous picture were moving normally. This sperm also has abnormally directed movement. It seems to flail back and forth, and that would be an abnormally moving sperm, and one we think probably not capable of fertilization.
Instead of number, is how the sperm moves very important?
Both the fraction of the sperm that move and how well it moves are probably much more important than number of sperm.
What about the actual shape of the sperm itself? We also have a slide that indicates, we can take a look in a moment, but do you look for the design of the sperm, so to speak, by taking a look at it?
We really don't know whether sperm, this is a normally shaped sperm, but all men have some of the rest of these so-called abnormal shapes. We don't know whether these that are abnormally shaped are capable of fertilization, but what we do know is that when there's an excess number of these abnormal shapes, that this is an indication that there is a problem in sperm production, and probably that the man's semen sperm production is responsible for the infertility of the couple.
Let us talk now for a moment. We assume here he has sperm, and we've seen his slide. Dr. Romas, what happens when there's no sperm in the semen?
This is a condition called azoospermia, where there's no sperm present in the semen. In that particular condition, we have several possibilities. Number one, the testes is not producing the sperm. Number two, there's an obstruction, and therefore the sperm can't get out to the outside.
Perhaps we could take a look at that slide again, the slide of the male anatomy, and while you were talking about this, we may be able to see it better. If you could show me what you're talking about now.
Now, the problems revolve around the fact that, number one, the testes cannot form the sperm. Second of all, you have some type of obstruction, which consists of, number one, either a blockage in this tube or a complete absence of either this structure here or the vas deferens, which conducts the sperm.
If I may ask, then sometimes this gets damaged or just blocked, and what it takes is you can go in there and free it up?
Various causes, either a congenital blockage, or number two, a blockage secondary to an infectious process that will cause the blockage.
And if a man is having a vasectomy, what you'd be doing is just actually cutting this on purpose.
Involuntary sterilization, the tube is purposely cut in order to prevent sperm from passing through.
I have to keep asking, where does that sperm go when it gets this far and the tube's been cut? It just falls in here somewhere?
Well, there is some back pressure on the testes, which decreases the production of the of sperm.
Now, there is an operation we frequently hear about. It's called a varicocele. And we do have another slide, but perhaps first you could, it's a bit complicated, but in short, correct me if I'm wrong, what it amounts to is a varicose vein here in the gonad, in the testes?
Yes, this is the way to look at it. It's so-called a dilated or a varicose vein around the testes, and we feel that there is some effect on the testes. In fact, there's effect on both testes in regards to the motility of the sperm, as well as to the there are a large number of abnormal forms present in the semen with this type of condition.
Now, I want to be perfectly clear about this. This is a vein that's going in there that just may be like a varicose vein. It's too large or swollen,
right.
All right? And your treatment for it then is, what do you do?
Well, if you feel that this is the only finding in the infertile couple, what we do is go in there in the groin area and ligate the vein high up in order to prevent the backflow of blood back into the scrotal area.
By ligate the vein, what do you mean now?
We mean that we tie off the vein so we can stop the flow of blood in a backward direction.
And it dies? The vein
does? Yes, the vein dies.
And Dr. Hembry, if I may direct, there's some controversy over this. Does it really do any good for male infertility?
I don't think that we can answer that with any definite conclusions. I think our approach, and a generally accepted approach, is that when a couple has been thoroughly evaluated, the woman is known to have all aspects of fertility normal, and the man has no other cause of infertility, a genetic cause, an infectious cause, an endocrine cause, no obstruction in the male tract, and when there really is left with no other type of obvious treatment, then we would recommend that a varicocele be repaired. The exact number of men who will respond and whether there is a direct cause-effect relationship is somewhat controversial, as you indicated.
Do you actually, have you done varicocele operations yourself?
Yes, I have.
And what's your feeling about it?
My feeling is exactly the way Dr. Hembry has just stated, that in cases that are fully evaluated, no other causal factors are found for the infertility, this procedure is worth attempting.
Just quickly now, to close, there really isn't a lot you can do for the man, is there, once you've discovered there's a sperm problem?
On the contrary, I think that if one is committed to evaluating the couple together totally, that if one sees an abnormality in the semen analysis, then at least 20 to 30% of these couples, pregnancies will be able to be achieved by careful evaluation of these other factors that I was talking about prior to a varicocele repair.
So you're saying 1 out of 5?
Right.
In the men? Okay,
I'm saying beyond that, perhaps as many as 30 or 40% can achieve a pregnancy with subsequent treatment. 20% will be treated by non-specific causes, finding infections in both the male and female tract, finding endocrine causes, improving the cervical mucus, as was talked about earlier. Other factors which may seem to be a male-related cause are actually a cause, an abnormality in the couple, which if one sort of tunes up the reproductive function of both individuals, a pregnancy can be achieved without this operation.
Okay, obviously there are alternatives to the conventional way of having babies, and if it turns out that nothing can be done, indeed one alternative is to decide mutually to have no children. Another choice is adoption, but in this day of contraception and abortion, that can be tough. A third alternative is artificial insemination. In that case, you have 2 choices, fresh sperm or frozen. There are some advantages to both. Recently, we visited a sperm bank on Madison Avenue. At this frozen sperm bank in Manhattan, a place called IDANT, carefully screened donors are paid regularly for semen specimens acquired through masturbation. Within 2 hours, it's processed, loaded into slim, straw-like containers. Some is cultured and later checked for infection, but most is put into narrow metal containers, which are then put under a slow freezing process and later held indefinitely. Meantime, a sample is checked for the condition of the sperm and the proper activeness, along with a sperm count. The specimen has to show a count of at least 110 million sperm, or the operators here say it isn't accepted. This sample passed 184 million. But why frozen sperm? Why not fresh sperm, used right away, as it's done in many doctors' offices?
I think that eventually fresh semen will not be used at all for the following reasons. Fresh semen cannot be checked in terms of effectiveness or absence of infection. There's a law on the books, for example, that every fresh semen donor should be checked 1 week before by culture to make sure that the specimen is free of any infection. This is rarely done, even though it's on a law. When you use frozen semen, you can check that very specimen. You culture the specimen, you freeze the specimen, then you see if anything grows out. So you've got much greater protection. But there's an even more important advantage when you use frozen semen. When you have a bank which contains several hundred different types of individuals, you have much greater selectivity in matching the donor to the sterile father. Now, when you have fresh donors, usually a doctor may have a population of only 2 or 3 donors. That gives him a very narrow match. He may be matching strictly for race. For example, we've had donors for Eskimos, believe it or not. We have donors for different types of Indians. Maintaining a population like this is expensive, but we feel it's important to do it that way.
Finally, I think the only real reservations that we have heard are from doctors who don't think frozen semen is as effective as fresh.
I think that this is a question that will be proven in time. For example, from this bank, we have over 1,000 documented pregnancies and probably a much larger number because we don't always get proper feedback from successful cases. So I don't think there's any doubt about the effectiveness. I might add one other thing, that there's a great deal of skill involved also in inseminating. And if a doctor has not been trained, if he's not familiar with the technique, he will not get a good result.
For some, then, these frozen containers, submerged in liquid nitrogen, hold the answer. But for others, the problem isn't conceiving. The problem is genetic. The couple, for example, who keep having defective fetuses who can't live. And for some would-be parents, that's agony.
I could honestly say at times I just couldn't cope with it. I didn't even want to live. I was that depressed. I mean, it was just the limit, because it was 10.5 months apart between the time we lost our first and our second, and I just couldn't cope.
How did you?
It was just a day-to-day existence. That was it. The hurt is still there. It never goes away, and you keep saying to yourself, why me? But when once our first child, our son, was placed in my arms, I mean, he was 2.5 days old, and that's the baby. I mean, that's it.
Sandy and Maurice Abrahams had no trouble conceiving, but as we said, together their offspring had genetic combinations that proved fatal 3 times, 2 stillborn and 1 aborted. And with little prospect for an answer, they turned to another solution, adoption. But we asked, where to find babies? We're told it's almost impossible.
If you want a child badly enough, and if you just let the world know that you're interested in the baby, one will come. You just can't sit home and say, well, a baby will come to me. You have to let everybody know, and anybody.
As an attorney, I had spread the word. I've spoken to several attorneys, as many doctors as I can get my hands on. Every friend and every relative I could tell them about that I was interested in adopting. Well, I guess some people may be ashamed of just asking people if they have need for help. I went out and asked for every possible person I knew, every relation, every old friend, every acquaintance, if they could help. And I was successful. I might say I was also very lucky.
Did you have to pay? I mean, was this through a private agency or attorney, or how did you come by the children?
Well, both of our children were adopted privately. The first one is ironic. We got through a priest. The priest was a friend of a girl that I used to work with who knew of a girl that was having a baby, and it was one of those things. Our second child we got through our dentist, who knew an attorney in Canada who handled adoptions, and we contacted him, and then when the children were born, we were contacted. But we were fortunate that we were not raked over the coals. There were no black market fees involved or anything like that. We did not have to pay exorbitant rates at all.
The Abrahams went through the adoption process 5 years ago, and unfortunately, since then, things have gotten worse, not better. Here with me now to discuss the current state of adoption is Hannah Grossman, who is Director of Adoption Services for the New York State Department of Social Services. Let's assume that I am in the position Mrs. Abrahams was, and I want to go through a legal process of getting a youngster for adoption. What would you suggest I do?
I would suggest that you go to an agency, a public or a voluntary child placement agency. The only other method, which is wholly legal in New York State, is to have a child placed with you directly by its mother or other very close relative.
So an intermediary, then, is not a legal process in the state, or at least not sanctioned.
That's right, it is not. And if there is any money that changes hands, it is clearly and definitely illegal.
Why does the state do that? Wouldn't it be easier to have an intermediary?
Well, it is generally found that a mother who is giving birth out of wedlock, the child, and the family interested in adopting receive more protection, more safety in a number of ways if there is an independent, uninterested party, such as an agency involved.
As opposed to an intermediary
who has an interest.
Clearly, people who have no chance of having a child of their own would like a baby. But abortion reform and new contraceptive methods have made this quite impossible. Or is it impossible? Are there babies out there to be adopted?
There are babies, and there are not. The number is not continuing to shrink, although it has shrunk in the last few years. Of the 2,500 adoptions that took place in New York State through agencies each of the last few years, at least half were healthy infants. But that number is not as great as the number of families seeking to adopt them.
Then who's available for adoption? What children are out there?
The children who are available, the children that we call the waiting children, are children who have come into foster care at some time because of the disintegration of their families, and who are now no longer infants, but now are available for adoption. Generally, they are at least 5 years old and older, or they are children of all ages with fairly significant handicaps of a mental, physical, or emotional nature.
Is it likely that parents who, not parents, but a couple who have never been parents would be able to deal with the youngsters with severe handicaps or emotional problems?
Some families have adopted older children and troubled children and received a great deal of satisfaction in watching these children grow, although their growth might not be the same and not start at the same point as that of an infant. But for many families, unless they've had a great deal of experience with the development of children in their families or through their work or in their communities, not only is this not what they're seeking, but they may not have the ability to handle it.
Mm-hmm. Well, we thank you for your comments and your insight. And we'll be right back with the rest of our guests to answer some of the questions that you phoned in. But first, Carolyn Weidman has some reading suggestions and other information for you.
In doing research for this program, we were amazed by the lack of materials on infertility. Yes, there were sex manuals and how-to books, but few that treated the topic of infertility alone. There are 2 books dealing exclusively with infertility that we can recommend. An Insight into Marital Infertility by Dr. Walter W. Williams is a book written mainly for the average person. It provides the reader with reliable information concerning the primary causes of infertility, including the type and order of examination, diagnosis, and therapy. Each chapter begins with a summary and ends with a list of references. In between are graphs and pictures to illustrate his clearly written text. Again, the book is An Insight to Marital Infertility, published by Carlton Press and priced at $7.95. The second book was written by Barbara Eck Menning and entitled Infertility, A Guide for the Childless Couple. Mrs. Menning, who herself is unable to have children, is the founder and director of Resolve, a support organization in Boston for infertile people. The first half of the book covers the medical aspects of female and male infertility, separately and as a couple. The second half includes a sensitive treatment of the psychological impact of infertility, exploring sexuality, self-esteem, and self-image, as well as alternatives to the infertile couple. The book is in paperback and published by Prentice Hall for $3.45. We also want to mention a booklet entitled Pathways to Parenthood. It's a general look at the reproductive system and the problems that can cause infertility, and the treatments which may be recommended. You can ask your physician to get it for you, or you can get a copy yourself by writing to Serrano Labs Incorporated, 11 Brooks Drive, Braintree, Massachusetts, 02184. It's also our custom to offer a kind of compendium of pamphlets and booklets we come across in our research, available from us to you through the mail. Our kit on infertility includes an anatomy diagram, a general pamphlet on the causes and treatment of infertility, some background on a New York area infertility support group, as well as information about adoption in our area. Finally, we included a collection of general information material for the patient, helpful to everyone dealing with health. To receive the Help Yourself kit, send $1 to Help Yourself, Infertility, Post Office Box 7070, Radio City Station, New York, New York, 10019. If you send a check, please make it payable to Help Yourself. Greg?
I might say that a great number of questions coming in over the phones we get the report have to do with the effect of marijuana on fertility. Dr. Hembree, that's kind of your bailiwick. Preliminary studies, I don't think you want to scare everyone, but does marijuana, in your mind, lower a man or a woman's fertility?
I can't answer this question specifically. I can tell you what we found, and that is in a very rigidly controlled study in the hospital, when chronic marijuana smokers were given large amounts, as many as 10 to 20 joints per day, in the hospital for a month, there was up to a 60% decrease in the total sperm count, a decrease in the overall movement of the sperm, and an increase in abnormal forms in the semen. This did begin to reverse itself within a few months, and we are currently studying chronic marijuana smokers who have abnormal semen to see just to what extent these abnormalities are reversible. Whether these abnormalities would cause a defect in their fertility, whether it would result in an abnormality of the children that were conceived, we simply don't know, and this is the subject of very much concern and of current study for us.
Dr. Grobner, the question is, what are the success rates for artificial insemination by donor if the woman has no detectable infertility problem?
About 30% of our couples conceive within the first cycle of trying, about 70% within 4 cycles, and eventually about 80%, which is just about what we will see in a normal couple with a healthy male partner.
Okay.
I have another follow-up question on that. Another person asked, is there any study of the children born from insemination, in other words, the normalcy and whatnot?
The normalcy is, as a matter of fact, higher than the average couple because we have screened one member of the couple for genetic defects, which the average married couple don't do when they marry each other. So there are less defects.
Interesting. Ms. Stein, maybe this one for you, if you can answer it. At what age should a couple give up trying to have a child?
I'm not sure that it's a question so much of age within the decade of the 30s, of the period of the years of the 30s, but more a question of how much frustration are they going through, how long have they been trying, how specialized are the people that they have been seeking help from, and how realistic are their chances at this point that there is still some hope.
So it's really a very individual answer.
Yes.
It's not a generalization.
As we are this evening, we're just taking these questions sort of potpourri that have come in through the evening, so I hope you'll forgive us if we jump around in subjects, because the next one, Dr. Romas, perhaps you can help us with a question. Does the size of the testicles affect fertility?
In general, there is a general size. In other words, if you're under a length of 3 centimeters and less than 1.5 centimeters in width, usually there is a profound effect on fertility. These are considered abnormal sized testes in the adult male.
Do you see that often? Is that a common undersize?
No, this is not a common finding. It's seen in some rare disorders where there are small testes present, and these are associated with other anomalies.
Dr. Grobner, viewer says she has a tipped uterus. Her doctor feels it's the cause of infertility. Are there any exercises to correct it?
Well, I think that it's a very common misconception that a tipped uterus in and of itself is a cause of infertility. It usually is not. There are certain pathological conditions that cause the uterus to be bound down and immobile, and sometimes these are associated with a tipped uterus. But a tipped uterus itself does not have to be corrected because it's really not a cause of the problem.
Dr. Hembry, a question that I've heard often. I've heard so much about mumps and male sterility. Is there any danger at all if a young boy gets the mumps before puberty?
No. No danger at all.
Joe.
What is Asherman syndrome? I'm not sure who should answer that.
Asherman syndrome is a scarring and a formation of adhesions within the uterus itself as a result of either an infection occurring at the time of an abortion or at the time of a D&C. Patients sometimes may not menstruate at all, or sometimes you cannot recognize this unless you do a hysterogram. It may prevent this uterus from expanding to allow a pregnancy to develop and is often a cause of recurring abortions. It can be treated surgically in a fairly high percentage of cases.
A caller asks, is there any hope if a male has less than 1 million sperm in his count and poor motility? Dr. Romas or Dr. Hembry?
I think that it depends upon, the hope is present if he has not been evaluated properly to determine whether he has an endocrine or an infectious cause for this. If indeed his endocrine function is normal and there is no presence of infection in the male tract and his sperm count stays at that level, then I would say the chances of a pregnancy occurring in that couple are extremely low.
Well, let's talk for a moment. There is a technique whereby you can take the husband's sperm and inseminate it and in fact give it a boost along the way.
I think that the so-called husband insemination, or AIH, that is done frequently probably is not a terribly effective way of achieving pregnancy in couples in whom there are abnormal postcoital tests and in whom there is defective semen analysis. It often is very valuable in being able to exclude an abnormality of the vagina or of the mucus, and being able, if one finds that with homologous insemination or husband insemination that sperm do survive in the mucus for 8 to 12 hours after the insemination, but don't after they've had intercourse, that may give you a clue that indeed there's some disorder of sexual function, or indeed there's a vaginal factor that may be involved in killing the sperm. However, as a therapeutic effort, I think that the experience has been not very good.
Two questions on endometriosis. One is it hereditary? And the second is a new drug called danazol, which has been heard of to treat endometriosis. Does it work in the same way pseudo-pregnancy does?
Endometriosis, as far as we know, is probably not hereditary. Danazol works in a somewhat different way than a pseudo-pregnancy. Pseudo-pregnancy overstimulates the abnormal endometrial implants, makes them dependent upon high doses of hormones, so when these hormones are withdrawn, the implants will in some way shrivel. On the other hand, danazol cuts off the stimulation by the pituitary gland to the ovary. So the ovary does not produce estrogen and progesterone, and the implants shrivel because they are no longer given their vital hormone supplements. So it works somewhat differently. The end result is pretty much the same.
Two questions that are related. I'd like to ask them together. The question number one, does an active sex life increase or decrease a man's fertility? Question number two, my wife and I are trying to have a baby. Our doctor says we should have sex every other night. Another doctor says every night. Which is better?
Well, I have a little bone to pick there. I think that any doctor who tells a couple when they should have intercourse is asking for trouble. I think that the couple has enough trouble without having their sex life regimented to that extent. We do know that a man can maintain a very healthy semen count on ejaculation every 48 hours. But on the other hand, a man with a good semen analysis can have intercourse twice a day, probably, and still will be fertile. So I don't think that that's a crucial problem. I think people are more concerned about when than they should be. I don't think that's important.
What about the question of an active sex life? Does that increase a man's fertility, or does it affect it in any way?
The more times a man ejaculates, the higher will be his motility, but perhaps the lower the count. So it's a reasonably good trade-off, and it doesn't seem to make a major difference as long as we're not talking about ejaculation an excessive number of times during the day.
Sort of related question. I read that the timing of intercourse can determine the sex of the child. Is that true? Anybody?
I think that the
silence, it must be unknown.
There have been conflicting articles published on that, and in fact one article which published just the opposite in one case indicated that timing of having sexual intercourse at one time gave rise to a higher instance of male births, and having insemination done timed at the other side of ovulation resulted in a higher instance of male births. So I think that we cannot conclude definitely that timing of intercourse makes any real difference at all. And again, I would echo Dr. Dubrovna's statement about the fact that people should be more concerned about enjoying their sexual function rather than the timing of intercourse.
Mrs. Stein, we have, unfortunately, we only have about a minute, but I would like you to approach this question at least, because my husband refuses to go and get tested. What can I do?
There are husbands who will have problems about going to be tested, and in that case, the woman can begin with the post-coital test to see that at least the sperm are happy in the cervical mucus, and to see that there are adequate and motile sperm, and it may not be necessary to go further from there. If it is, then in that case I think counseling is indicated for that couple.
Well, just in a very short period of time, do you have any hints about how a woman can get her husband to be checked? Have you ever come across a technique?
A technique?
Get him to come in and
to get him to come in.
Well, before he comes in to be checked by a urologist, I think it would be a good idea to have the couple come in together and just discuss what their goals are in starting a family.
Which is a good note to end it on because we've run out of time, Greg. We do want to thank all of our guests, Hannah Grossman, Roselle Schubenstein, Drs. Dubrovna, Hembry, and Romas. Also, a special thanks to the United Infertility Organization for providing us with so many people to answer your questions tonight. If you'd like more information, you can call their hotline. The number is area code 914-723-1687. Remember, that's a 24-hour answering service, 7 days a week. You just leave your name and number, and a staff member will return your call as soon as possible. And finally, if you'd like our kit for this program, send $1 to Help Yourself, Infertility, Post Office Box 7070, Radio City Station, New York, New York 10019. Right?
Thank you, Joan. We'll be back on June 8th with the first of 5 parts.